Good evening, everyone. Thank you for joining us for tonight's webinar, Living with Ovarian Cancer, organized by the Florida Society of Clinical Oncology. FLASCO is a member-supported state society that focuses on supporting and representing the oncology workforce of Florida. Together, FLASCO is the voice of oncology in Florida. Many of the individuals participating in this webinar are FLASCO members, and we appreciate their support. Hi, I'm Dr. Natalie Dauphin-McKenzie. I'm a GYN oncologist at Advent Health Cancer Institute, and I serve as the Director of GYN Oncology Fellowship at the Cancer Institute. I will be serving as both moderator and presenter for the webinar tonight. Our oncology experts and I will discuss ovarian cancer and treatment options, as well as more individual-focused areas, including support for caregivers and patient advocacy. We'd like to thank GlaxoSmithKline for supporting this webinar and making it possible for us to share this important information. Before we begin the presentations, I'd like to let everyone know that this webinar is being recorded so that those who were unable to attend can view it at a later time. Also, your lines will be muted for the duration of the webinar. Toward the end of the meeting, we will host a Q&A, and we encourage you to submit your questions on comments via the screen. There is a question box on your GoToWebinar panel, and we will discuss as many questions as time allows. It's an honor for me to introduce our accomplished group of panelists for this evening's webinar. I will briefly introduce them now, but please read their impressive bios in the meeting packet that was emailed to you. The link to download the meeting packet is in the handouts box on your GoToWebinar panel. Now I'd like to introduce our panelists. Our first panelist is Dr. Robert Holloway. He is my partner at Advent Health Cancer Institute here in Orlando, where he serves as the medical director of the Gynecologic Oncology Program. He is also a founding member of the Global Robotics Institute and is internationally recognized for his pioneering skills in robotic surgery, postgraduate training programs, and excellence in clinical research. Also joining our panel is Marlene Morales, a licensed clinical social worker at the Sylvester Comprehensive Cancer Center. She also has a master's in Certified Addictions Professional and International Certified Alcohol and Drug Counselor. She has over 15 years of extensive experience in working with diverse populations and has multiple areas of expertise. After the Q&A, we will hear from our final panelist, Dr. Michael Diaz. Dr. Diaz joined Florida Cancer Specialists and Research Institute in 2011 and currently serves as its executive board and as the assistant managing physician and vice president. In addition, he serves as the director of patient advocacy for FLASCO and on multiple work groups for ASCO. He also serves on the boards of other organizations, including Oncology Alliance and National Cancer Treatment Alliance. Thank you, panelists, for joining us to share your insight on the mechanisms of living beyond ovarian cancer. Let's kick off the presentation with my own presentation, which is what is ovarian cancer. Good evening, everyone. I'm so happy that all of you could join us tonight. So let's talk a little bit about what is ovarian cancer. Well, we know, many of us know, that female reproductive organs include the cervix, the uterus, the fallopian tubes, and the ovaries. The ovaries make the female hormones estrogen and progesterone when women are in their reproductive ages. So those are the ages during which women have their menses. The ovaries, unfortunately, can also be a site of cancerous development. And there are many different types of ovarian cancers, which include epithelial ovarian cancer, germ cell ovarian cancer, and sex cord stromal ovarian cancer, and a few other rare types. Now, ovarian cancer, fallopian tube cancer, and primary peritoneal cancer are all lumped into one because these diseases really mimic each other in terms of presentation, how they're treated, and in many ways, how they're staged and how they're classified. And so when you think about these collective diseases, ovarian cancer, fallopian tube cancer, and primary peritoneal cancer, we tend to divide them not so much in these locations, but more in terms of epithelial ovarian cancer, which is the most common type, and then the germ cells and the sex cord stromal tumors that are less common. The epithelial ovarian cancers, which are the most common types, usually are called the whisper disease. And the reason it's called the whisper disease is because women often experience vague symptoms. Symptoms that are so vague, in fact, that it makes it very difficult for the patient to know that something's truly wrong, let alone an unexperienced physician, which is why it's really important for our women to get themselves to an expert as quickly as possible. So let's talk a little bit about these vague symptoms. If a patient is fortunate enough to experience pelvic pain or abdominal pain, then she may present more quickly to a physician or an emergency room where some sort of imaging study will be performed. Unfortunately, many other women don't experience pain. In fact, what they do experience are things like abdominal bloating or increase in waist size or pant size or belt size, urinary frequency or urge frequency. Other symptoms that are also fairly common and vague include early satiety. Early satiety means feeling full quickly or even not having the desire to eat very much at all. So if you think about these vague symptoms such as indigestion, feeling full quickly, urinary frequency, you can see how these symptoms might mislead both the patient and perhaps their primary care physicians. That is why, especially during the month of September, with this both GYN cancer and ovarian cancer awareness month, we go through great lengths to educate the general public as to what these symptoms are like, so that patients can remember and physicians can remember to investigate these symptoms a little further and hopefully refer the patient to experts like ourselves. Now, ovarian cancer, germ cell cancers, for example, tend to occur in patients in a younger age group, usually in the teens or the early 20s, and of course can occur in other age groups, but those are the age groups where you most commonly see the germ cells. The sex cord stromals are mostly found in the reproductive ages, but certainly can be seen in younger ages and postmenopausal age group as well. The presenting symptoms there usually are very large ovarian mass, and the appropriate tumor markers are usually ordered by an expert who knows which markers to order to better differentiate between those. It's always better to have an idea for the physician what they might be dealing with, because they are better prepared for the type of treatment and the type of surgery that the patient may be experiencing or may need. So let's talk about sexual stromal tumors, for example, like granulosa cell tumors. Those can present with a large mass. We have specific tumor markers that we typically order that help us differentiate between these from the others. These patients can also present with ascites. Sometimes the ascites can be a little bloody. These patients also have abnormal hormonal regulation, and as a result, they may have abnormal uterine bleeding because of this hormonal regulation, and they may even develop breast issues, breast messes with granulosa cell tumors of the ovary. So these are some of the symptoms that you might experience, a patient might experience with ovarian cancer. And the age group for epithelial ovarian cancers, you're looking at more your postmenopausal age group. The typical age, the average age is 65, ranging anywhere from the 30s all the way to the 90s. When we are dealing with patients who are diagnosed in the premenopausal age, we begin to wonder if maybe there's a familial link there, if there's a hereditary component, which takes us to hereditary ovarian cancers, which account for approximately 15 to 20 on average. And the great majority of ovarian cancers are called sporadic ovarian cancers, which mean that they occur by chance. We do know that lifestyle factors play a role in some part in the development of malignancies. However, science to date has not allowed us to pinpoint exactly who and how and at what critical point one falls into that risk. And so when we think about lifestyle factors that can contribute to really any cancer, we think about diet, we think about sedentary versus active lifestyle, and all of the things that can stress the human body, which includes lack of sleep, chronic stress, um, and um, and the ability to feel well and whole. So hopefully that is a brief discussion of what is ovarian cancer. And again, we'll have questions that we can answer at any time. And of course, we can answer these questions towards the end of our panel as well. So now I'm going to talk about treatment for ovarian cancers. So we've come a long way in the treatment of ovarian cancers. Once upon a time, we had one or two drugs that were fairly toxic and not efficacious. We also didn't have the opportunity to really understand the spread of the disease and how it could be treated surgically. We've come a long way. One of the first biggest advances was the addition of paclitaxel to carboplatin for ovarian cancer, and we were able to see a rise in the number of patients living longer with this treatment combination. Surgeons then began to better understand that with radical debulking of tumors and really taking time to leave no tumor behind, what we call R0, reduction or debulking of the tumor to no gross residual disease makes a difference in overall survival. So the second leap, historical leap in the survival of ovarian cancer patients came with the advanced surgical techniques that we all now perform to really make a difference and giving those patients that survival advantage. And that means removing bowel if necessary, removing parts of the spleen, doing things like what's called a peritonectomy or diaphragmatic resections or splenectomies. All of these, removing parts or some of these organs to really decrease the total tumor burden makes a huge difference in ovarian cancer survival. Some patients, however, present too late. They just can't be debulked at that point. uh, and neoadjuvant chemotherapy. Chemotherapy prior to surgery has its role today. And we are, as experts, we are able to determine who is the best candidate for cancer before surgery or for surgery before any type of cancer. And we have algorithms that we use to make the difference, and we use CA-125, the patient's overall functional status, as well as imaging studies to make that decision. Moving on beyond carboplatin and paclitaxel, extensive surgical debulkings for ovarian cancer, now we have targeted treatments. We have treatments like PARP inhibitors and immunotherapy and a slew of other systemic chemotherapy drugs that are now mainstream and standard of care for patients with ovarian cancer. We better understand which drugs that we can use after chemotherapy as maintenance drugs to further enhance that survival advantage. And so all of these put together have slowly but incrementally increased the amount of patients living with ovarian cancer. So we are in exciting times, and I would say that now more than ever, there are new drugs on the market more rapidly. There are new clinical trials that are offered to our patients more often than not. And so this is really exciting. I don't want to take too much of Dr. Holloway's thunder because he is going to be talking about clinical trials and other treatment options for ovarian cancer. So without further ado, I'll turn it over to Dr. Holloway to turn on his webcam and continue the webinar with his presentation on ovarian cancer treatment options. And whenever you get a chance, you'll turn on your microphone.
I've got the microphone on. There you go. So I made it home, and I grabbed a few crackers, and I propped my feet up on the stool, and I'm on the couch in the man cave, and I am just finishing a long day in the office. So this is really what we talk about in the office every day. And part two, I thought what I'd really address is why do we consider clinical trials? And in ovarian cancer, where are the clinical trials going? So Dr. McKenzie talked a little bit about what is ovarian cancer and what are the general treatments. And you heard that the standard treatment for epithelial ovarian cancer is upfront carboplatin or platinum-based therapy, carboplatin or cisplatin-based therapy, usually carboplatin. And we more or less divide patients after that, if they get a recurrence, into groups of whether they responded to platinum and got 6 months of remission, at least 6 months, that's platinum sensitive, or less than 6 months platinum resistance. And those are kind of general constructs about how we think about treatment of recurrent disease. So how do clinical trials come into this? I oftentimes have to think back and remind patients that when I was in my early training, there were women who actually enrolled on a clinical trial to test whether Taxol with carboplatin was better than the current standard of care, which was cisplatin and Cytoxan. And so prior to me getting into GYN oncology and residency, we learned that cisplatin had made such a difference in the management of ovarian cancer. It was so much better than Cytoxan. And the standard of care at that time was cisplatin with Cytoxan. Then came along this new drug Taxol. So it goes through early phase testing for toxicities, phase 2 testings to see what the response is as a single agent. It eventually got combined with cisplatin, and there were early clinical trials in the GOG that did a comparison of the combination with Cytoxan and platinum. And so sometimes patients are very averse or anxious about going on clinical trials. And to keep it in perspective, I have to think about the fact that there were women in the late 80s who decided to go on a clinical trial and go away from potentially the standard of care, take a 50-50 chance they're taking a new drug in hopes that it did better. And then looking at that, those patients who got on the Taxol arm actually ended up doing a lot better. And it was a 50-50 chance of getting on the new drug or the standard drug. And so going on a clinical trial usually offers some element of risk assessment and benefit assessment to determine, what are the reasons you would go on the trial. And at the end of the day, you have to look at what is standard of care and are you happy with that? So if you are, you may not want to go on a clinical trial, but if you want to try to do better than standard of care, and better could be a better response rate, a better time to progression, or a better remission rate, or a better chance for cure, or it could be less toxicity. That could be the point of the trial to see, can we get the same response and survival with less toxicity? So another general point that I want to bring up, there are different phases of trials. I mentioned that briefly in the introduction. So a phase 3 clinical trial is really comparing a standard of care treatment with a new treatment. So when you look at that trial and you assess risk, at a very minimum, you're going to get standard of care. So in other words, if you didn't go on the clinical trial, I'm going to offer treatment A, which is standard of care. Now, if you go on the clinical trial, there's a 50-50 chance you may, through random selection, be on the experimental arm. So then you have to look at what's the background of the drugs on the experimental arm and how did they bring this to trial. And usually there's a volume of data on phase 2 testing to see what the efficacy was in smaller clinical trials. And usually that data would suggest that the treatment is at least as good, if not better. Otherwise, it would have never made it to a phase 3 trial. You'll also have data to look at what's the potential side effects and toxicities of the drug to help make a judgment. A phase 2 trial is obviously an earlier phase trial. A phase 2 trial means everybody gets the experimental treatment. And that phase 2 trial is really meant to measure what is the estimated efficacy of that drug. And usually it's a smaller trial. The results of that phase 2 trial will then allow the development of a randomized phase 3 trial. Why would you go on a phase 2 trial? Usually, phase 2 trials are usually done in settings of recurrence of disease, and again, oftentimes in a setting where you have more limited options on treatment. And so with some background data on that drug, you can make a decision, would I rather take a standard treatment option, and here's what the estimated response probabilities are and the estimates of toxicity, or would I rather look at this experimental treatment, which usually has some earlier phase trials that can give you some hint of the possible efficacy and side effects or toxicity. And then, of course, going before a phase 2 trial is a phase 1 trial. Phase 1 trials are usually small studies, usually not performed in as large of number of institutions, more select institutions that take patients who usually have been heavily pretreated and are really down to very limited treatment options. So to go on a phase 1 trial, you've usually recurred more than once and have usually gone through several lines of standard of care drug therapy or other clinical trials. And a patient going on a phase 1 trial usually is at a point where you would say, I really have very few treatment options available. Um, Here's the last option available, and the efficacy isn't known to be very good, and here's the toxicity. Or you could look at a phase 1 trial. And a phase 1 trial for that patient really is an experiment. Usually there's very little data on the drug. A phase 1 trial is actually designed to measure toxicity, and it's oftentimes conducted in a dose escalation fashion. And the main purpose of a phase 1 trial is really to define the tolerability of the drug and or the side effects. Now, anytime a phase 1 trial is conducted, we also look for evidence of efficacy because it helps generate information that would help you propose it as a phase 2 study if we see efficacy. But sometimes in a phase 1 trial, and this is all a statistical calculation based on a number of patients estimated for that trial, sometimes there will be very little efficacy identified in this phase 1 dose escalation study, and the decision will be made that not to bring it forward even into a phase 2 trial. You might define toxicity, but the efficacy could be disappointingly low and not advance the drug. I went in reverse order, really so you could understand that as you get into earlier phase trials, usually you have fewer options. If you're looking at a phase 3 trial, it's usually you have a very good option with standard of care therapy. And so you're actually looking at a drug combination that could be at least as good as standard care and hopefully better. And then you're just kind of weighing risks of toxicity with those trials. We have all levels of these trials available at Advent Health in ovarian cancer, as well as the other diseases that we treat. In ovarian cancer, there are new drugs on the market as of the past few years. Dr. McKenzie mentioned PARP inhibitors and immunotherapy. And a lot of the current trials around the world are looking at how do we best use immunotherapy and PARP inhibitors, and oftentimes in combination with other therapies. Immunotherapy has made a big impact in some oncology spaces, in melanoma, cancer, and is gaining traction in cervical cancer and even uterine cancer. It has not had a big impact in ovarian cancer, and that's because of the properties of ovarian cancer cells in general. They tend to be more hidden from the immune system. Immunotherapy, when we use that term, we're really talking in general about checkpoint inhibitors as a class of drugs. And they more or less take the brakes off the immune system. And it turns out that the native immune system that we have is really geared towards repression of our T killer cells, and that's really so we don't have autoimmune disorders, and so we don't cause so many inherent autoimmune diseases by suppressing the T cell response. So it just turns out the ovarian cancer, epithelial ovarian cancers in general, don't elicit much of an immune response. They aren't really recognized as being foreign in the majority of patients. Now, it appears that up to 50% of patients do have a T cell response with their ovarian cancer. In other words, by doing biopsies and staining for specific T cells, you can find what's called TILs, T infiltrating lymphocytes, in their tumors in up to 50% of cases. Patients who have a TIL response do enjoy an improvement in remission, response, and survival. In an early study published back around 2004, 2005, I believe, in New England Journal, patients who had TILs had a 48% chance for 5-year survival compared to a 4% chance with no TILs. Of course, our ovarian cancer chemotherapy has changed quite a bit since then, and those numbers would change in modern populations. But but it was the first evidence that there was some interaction with the immune system in ovarian cancer. But it's just that I think in more modern studies, the population that has infiltrating T cells is probably less than that, probably in the 20% range. So the clinical trials that we have that I want to briefly mention, I would break them down by category. So as far as an upfront primary diagnosed patient looking at their first chemotherapy with a new diagnosis of epithelial ovarian cancer, we currently have a clinical trial looking at introducing immunotherapy into the frontline setting with chemotherapy. And these are for patients who are going to undergo neoadjuvant chemotherapy. As Dr. McKenzie discussed, approximately 50% of our patients we think would benefit from chemotherapy before surgery. They're usually very advanced with bulky disease in the upper abdomen, large volume ascites, or involvement of solid organs like liver, spleen, lung. And so we usually start with chemotherapy to try to reduce the disease burden and make it more likely that we can get a complete gross resection at their surgery. In this clinical trial that we have, we biopsy the tumor laparoscopically and then place an intraperitoneal port. The patients are randomized between standard carboplatin Taxol or carboplatin Taxol with an intraperitoneal plasmid that contains a gene that codes for interferon. This plasmid gets inserted into cancer cells, and it has a selective target mechanism to where it targets cancer cells. And this gene plasmid will then produce interferon on the cell surface. Interferon is a natural protein substance that is in our bodies to attract white cells, T cells. So this is a mechanism of attracting the T cells to the cancer cell. And while you're giving chemotherapy, you cause cell death. Cell death produces protein from the cancer cells that then excites the T cells that you're attracting also through the interferon system. And this is a quite exciting treatment protocol and makes a lot of sense. We've known for a couple decades that intraperitoneal interferon improves chemotherapy response and survival. The problem is it is so toxic that it has never really come to an actual treatment. The early studies showed efficacy, but horribly toxic, difficult to manage the patients, and there were deaths along the way managing complications of intraperitoneal interferon. Using this plasmid system, though, you're producing very low levels of interferon on the cell surface, so it's not so toxic, but it attracts the white cells. Very unique. We have another protocol that will be opening soon for patients who undergo primary surgery, and they will be randomized carboplatin Taxol to carboplatin Taxol with an antibody or agovimab. The antibody is directed against CA-125 on the cell surface, makes the cell look abnormal, attracts T cells. So it's another way to get the immune system involved with the chemotherapy treatment. And I think both of these are very exciting protocols. On the recurrent side, we have a protocol for platinum-sensitive patients that's looking at giving non-platinum-based therapy to a platinum-sensitive patient in order to avoid the toxicity of repeat platinum dosing. And this uses 3 different drugs, a PARP inhibitor, a MEK inhibitor, which is another metabolic pathway, and immunotherapy. So the design is to use interruption of these other metabolic pathways to make the cells look abnormal and hopefully achieve a better response with the immunotherapy, which really doesn't have much in the way of single agent response for most patients. And then on the platinum resistant side, we have a protocol that's using immunotherapy with a PARP inhibitor. It's theorized that those two would be synergistic, again, by creating cell death, creating more abnormal protein, and attracting the T cells, and then hitting it with the immunotherapy, which would take the foot off the brakes for the T cells. We also have another platinum-resistant protocol using immunotherapy that uses another checkpoint inhibitor. There are 2 checkpoint inhibitors that are FDA approved. There are several that are under development. So this is using one of the checkpoint inhibitors under development with something called an immunoemulsion, which is a factor that essentially attracts or excites T cells to the tumor. These are phase 2 trials now in the platinum-resistant setting that I'm talking about. So we have several to offer patients, and where we have to go through these and look at eligibility criteria. They're all very specific for how many prior treatments and what kind of treatments. We can usually find a slot for a patient based on their prior treatment and get them into a clinical trial. I think that's the majority of the clinical trials we have. We also have one last exciting one I want to mention to you. Tumor treatment fields. So it turns out that by alternating magnetic pulses, you can affect the cell division mechanism. And there has been a system that has shown some efficacy in glioblastoma, the brain. So it's a cap that goes on the skull that uses alternating currents to affect the way the molecules inside the actual cells line up. And by doing that, you can disrupt cell division. Cancer cells are more rapidly dividing than surrounding normal tissue, and so you get more interruption of the cancer cells than the normal tissue with this. Well, they've now designed, instead of a cap on the head, a belt or jacket that goes around the abdomen, and we actually are opening a clinical trial that is using alternating currents to create a treatment field in the abdomen with weekly Taxol, so standard Taxol. And this is a randomized phase 3 weekly Taxol, which is really one of the most effective platinum-resistant standard of care options, versus weekly Taxol with the alternating treatment fields. So we have a lot of exciting work going on in clinical trials for patients with ovarian cancer. And I think that many of these trials are going to bear fruit and hopefully will be brought forward as more standard care treatments in the next decade. So with that, I'll close off. Maybe that was more than you wanted to know about clinical trials. And I'm not sure who is coming on next, but somebody else can jump in and take over here.
Thank you for sharing your valuable perspective, Dr. Holloway. I'd like to remind all attendees that if his presentation brought up any questions you'd like to share with us, please type them in the question box, and I'll be sure to read them as we continue on our discussion during the Q&A portion. Please note that we will definitely make sure that all of your questions are addressed as soon as possible. Next, we will hear from Marlene Morales, who will turn on her webcam and discuss patient assistance programs and caring for the provider.
Hi everyone, my name is Marlene. I'm the licensed clinical social worker for all gynecology oncology patients at Sylvester Comprehensive Cancer Center. I am an oncology social worker and I work with gynecology oncology patients on a daily basis, specifically ovarian cancer patients. I've developed a flyer for you guys to look at of ovarian cancer resources available in the community. This flyer, it's not all the resources available, but it's some of the resources that I utilize with patients on a daily basis. So a lot of the things that I do is I provide emotional support. I am a mental health professional, so I do have emotional support groups for patients for gynecology oncology at Sylvester. But I also help with obtaining oral chemo medications like olaparib, niraparib, trametinib, everolimus when insurance companies don't pay for your medications that you're being prescribed. I'm the person that researches these programs and the manufacturers to try to get these programs for you. What I've added is also the transportation resources. I'm not going to go in order, so there's a lot of information. I help patients with transportation, for example, getting to their appointments. I know that COVID has impacted the community very much, and I know a lot of patients reach out to me when it comes to transportation, because the American Cancer Society used to have Uber and Lyft drives for the patients, but no longer because of COVID. So I am the person that they reach out to, because there are transportation resources in Miami-Dade County, Broward County, Palm Beach County, and then but there isn't any transportation that crosses county lines. So you might reach out to me to see if there's if there's a resource available for you. In addition, what I've added is there's phone numbers for utilities if you can't pay for water. I've added the numbers on the resource list so you can call to see if you can decrease your bill or not have to pay your bill at all. In addition, on the left-hand side, you can see a lot of financial assistance programs. These are by criteria, by diagnosis, depending on your financial criteria. They're the ones that I commonly use. You can always reach out to them directly and apply, but most of the financial assistance programs would usually utilize a social worker because they also advocate on your behalf. One of the things I also interact when it comes to patients is the caregivers. I often talk to the caregivers on a continuous basis because sometimes the patient is too tired, you're fatigued, you don't want to deal with any more stressors. So I've developed a short ovarian cancer caregiver resource pamphlet that you can take a look at. I think that on the ovarian.org, that's actually a PDF booklet that talks about tips and burnouts for caregivers. And all these programs, because I looked it up before making it for you, they all have online support groups specific to ovarian cancer caregivers. So one of the popular ones that I looked at that caught my attention was Cancer Care and the Cancer Care community. They actually are taking new members after October 1st. So, click on the link, take a look at it. That's going to be available to you. Things to look out for. I know some people don't want to always reach out for assistance. Is as far as the caregivers, be aware of your own physical health, your own mental health, emotional health. Realize that you can't do it all on your own. Please reach out to your social worker at your local facility and speak to them because they are full of knowledge. Your psychiatrist, psychologist, any cancer support services that are available at your center if you're feeling any type of burnout or fatigue. Now, if I've gone too quickly, please feel free to ask me any questions afterwards. I'm happy to speak more and elaborate more on the topic.
Thank you for your presentation, Marlene, and for highlighting caring for the caregiver, as that is an important role that is often overlooked. Cancer affects each population differently, and minority groups in the United States bear a greater burden for many cancers. The Florida Society of Clinical Oncology is actively fighting cancer disparities on many fronts. On your cancer journey, you can do your part by making sure you just ask. Help us narrow the gap. To learn more about cancer disparities in ovarian cancer, please download our Disparities in Ovarian Cancer slide packet and Minority Cancer Awareness handout located in the handouts drop box on your GoToWebinar panel. We will now move on to the Q&A portion of the webinar. I'll read the questions, and then our panelists can decide who will answer each question. How do you know if you fall in 50% of women have TIL's response? That's for Dr. Holloway.
It's not a standard pathology test, but I think more and more it can be requested. Our own pathology lab, for instance, will now stain for what's called CD4 and CD8 T cells, but it's not really a standard pathology test. I'm sure there's probably issues in getting it paid for by insurance. It hasn't really become mainstream as a diagnostic test, and we haven't really found what to do with that information. It's a prognostic factor and not necessarily anything that we can use clinically. That is really on the forefront of research right now, and I feel certain in the next decade this will become a more standard thing to try to describe what's called the microimmune environment of a patient's tumor, and we'll have more and more drugs that will manipulate the immune system and the immune environment. There's a very close interplay between standard cytotoxic chemotherapy and the immune system that we need to understand more and learn how to respond on a month-to-month basis and manipulate to really get optimal results. And we're just, as I say, when we talk about this now, it would kind of be like talking about antibiotics in the 1940s, when we just discovered penicillin. Now that's really where we're at, manipulating the immune system right now. So.
Thank you very much, Dr. Holloway. The next question for our panelists, including me, is what percentage of ovarian cancer patients don't recur? The question is, we know there's a very small percentage, but what percentage don't recur? And that really depends, and I'll let Dr. Holloway chime in as well, but that really depends on the stage at presentation. Therefore, if the patient presents at stage 1, the likelihood of recurrence is going to be much lower than if a patient presents at stage 4, where there's a 90 to 95% chance of recurrence. And so stage at presentation plays a huge role in that number. I hope that helps answer your question, but there have been patients who have had radical remissions. There have been patients who have lived extremely long lives after ovarian cancer. Yes, that number is small, but it's not zero. What would you like to add, Dr. Holloway?
Well, I agree. It's very stage dependent, but I think actually even in advanced stage 3 disease, the 5-year survival number has crept up over the years, and that's because of the new treatments and better surgery and better supportive care. But the real number that I have paid attention to is what percentage of patients get surgery plus chemotherapy and never recur, and I think that's the essence of this question. And with stage 3 disease, advanced stage 3 disease, it's roughly 20%, 20 to 25%. So that's actually a fairly significant percentage of patients just get one go with surgery and chemotherapy and never relapse. So it's not really true that everybody who gets ovarian cancer recurs. That's really not true. The vast majority do. And there are predictive factors, and that's based on, the primary driver is resectability. If you can get a patient to no gross resection, then that kind of gets them in the ball game. And then it's biology of the tumor. And that's where we're going with the testing, to look at the genomic DNA signatures and probably description of the microimmune environment. And we're just, again, on the cusp of being able to do that. And I think there'll be much more in the next decade where we can individualize therapy rather than give everybody carboplatin Taxol. It'll be a cocktail of different things based on what we see inside the actual genetic makeup of that tumor. And that's going to involve the immune system in a big way, I truly believe, in the next decade.
Wonderful. Thank you so much. Marlene, this next question is for you. Apologies. Are there any resources for patients or caregivers that are specific to the burden brought on by COVID-19?
So this one you have to constantly check on. I would call the American Cancer Society to find out which COVID-19 emergency relief funds are available. I believe it was, I'm not sure if Cancer Care has their funds open or if, give me one second, the Patient Advocate Foundation has their financial assistance for COVID-19 patients. But if you forget anything that I've said, you have to call the American Cancer Society. That is your local database to find out anything that's new, any type of financial assistance that's available for patients. That's what I often do if I can't find it. But right now, from my understanding, because I checked yesterday, they're closed. So I mean, there is financial assistance on the flyer that I provided. For the Women's Cancer Fund, you can always apply. They can give you up to $250 to assist with any electricity, water, cable bills that add up to $250. The Florida Cancer Specialist Grant can provide up, I believe it's to $1,500 for patients for household bills. You can apply with your social worker. There's different types of financial assistance that you can apply despite of COVID that's available, but from my understanding, the ones that I know about are closed.
Excellent. Thank you so much. Let's make sure that there are no other questions yet. There's one more, Dr. Holloway. You mentioned that there are FDA-approved checkpoint inhibitors, which can be used to treat epithelial ovarian cancer, specifically pembrolizumab, which is otherwise known as Keytruda. And the question is, how are they used? I guess the best is when.
Yeah, when? Well, right now they're used in the recurrent setting. They're intravenous infusion. These are antibodies, and they're intravenously infused every 3 weeks on average. And in ovarian cancer, they do have some activity. The relative percentage of patients who get a good response is relatively low, though, probably in the 10% or under 8, 9, 10%. We do have predictive stains in the tissue for PD-L1 that can help tell you what your odds of response are. So if you're at the highest level of staining, the clinical studies would indicate you could get up to a 17% chance for response, and then if you're staining intermediate, it might be a 10%, and if you're staining low, it's in the less than 5% range for PD-L1. The kind of interesting thing, though, while those odds don't sound so great, if you get a response, it can be long lasting. You can be on checkpoint inhibitors for a long period of time, years, and still keep getting response with relatively little toxicity. So, we need to have more research and understanding what is it beyond PDL staining. There's got to be some other factors that we can figure out, who is really going to respond. The second thing is combining checkpoint inhibitors with other pharmaceuticals to make the immune system more active. And that's another broad area of research that is going on that will kind of help make checkpoint inhibition more of a viable alternative for more patients with ovarian cancer. The other thing I wanted to mention, I thought about this when I hung up, is I didn't mean to make this discussion about clinical trials so centric exactly to our practice. And I do want to mention that because I realize that there could be patients from all over the state. Every major academic center in the state has clinical trials programs, and I did want to make a call to say that when you're in your frontline therapy for ovarian cancer, that's the time to start asking your providers about clinical trials. And in addition to the academic centers, Florida Cancer Specialists has a huge clinical trials program. So I think it's important for patients and their families to start asking questions about that early on, so you can kind of start making decisions as you come down the road about maintenance therapies. Is it going to be on or off a clinical trial? And then, of course, if there is a recurrence, start looking then for clinical trials to compare to what is considered standard of care. Clinicaltrials.gov is the nationwide clearinghouse for clinical trials, and that's housed at the NIH, or National Cancer Institute. And every major clinical trial done in the United States is registered at clinicaltrials.gov. So you'll be able to see what's in Miami, what's in Jacksonville, what's in Tampa, what's in Orlando, and it's a good resource for cancer patients looking for clinical trials. Flasco also has a clinical trials registry on their webpage that providers and patients can view. So just want to put a little plug for how do you find clinical trials, and you start by talking to your practitioner.
Wonderful, thank you so much. We have one last question. Lynparza, what is your take on it? So Lynparza, for the benefit of the other attendees, is a PARP inhibitor. There are currently 3 PARP inhibitors that are mainly used in ovarian cancer these days. This includes Lynparza, or olaparib, it's its generic name, rucaparib, and niraparib. So these 3 drugs are PARP inhibitors, and Dr. Holloway is going to talk to you a little bit about how PARP inhibitors work.
Put me on the spot. So, well, you know, it turns out that we have natural proteins that repair DNA damage. We all suffer DNA damage every day, hundreds of thousands of times, where we have cells that are dividing and they make a mistake in their cell division, and you end up with breaks in the DNA in those cells, and there's usually single strand breaks. PARPs are proteins that we are all genetically coded with to repair single strand breaks. So the class of drugs, PARP inhibitors, were created to interrupt this repair of the DNA damage that we normally suffer. Now, it turns out that cancer cells are more rapidly dividing. So in any unit of time, cancer cells in a tumor are going to have more DNA damage than surrounding normal tissue. So if you introduce PARP, you'll get more cell death in a tumor than you would in normal tissue. The most rapidly dividing normal tissue we have is our bone marrow. And some of the side effects of PARPs are naturally anemia and thrombocytopenia, lowering platelet count. And that's because those are our most rapidly dividing normal cells. So it's a new important class of drugs. Where they've been particularly effective, though, are for patients who have the BRCA mutation. As Dr. McKenzie mentioned, about 20% of patients have a mutation in BRCA1 or 2. They are particularly sensitive to PARP inhibitors and get a huge benefit with PARP inhibition. And that's because if you inhibit single strand breaks, you accumulate double strand breaks, and that leads to rapid cell death. It turns out the BRCA gene codes for proteins that, like PARP, repair DNA damage. It's just that they're experts at repairing double strand breaks. So if you have a patient genetically carrying a altered copy of BRCA, they really don't repair double strand breaks so well. If you front load the system with a bunch of single strand breaks through PARP inhibition, it causes cell death. So patients with a BRCA mutation, you can think about it paradoxically, had a higher risk to get ovarian cancer, but paradoxically, they have a better percentage chance of getting a benefit from a PARP inhibitor. There's other classes of genomic signatures that we call HRD that are almost as good as a BRCA mutation. So it turns out that about half of patients have a really decent chance of getting a response to PARP inhibition. And even the patients that aren't HRD or have a BRCA mutation, they can get a benefit from PARP inhibitors, but just not to the degree. So It's an oral drug, relatively new class, mostly used in maintenance once you've gotten a response to therapy. And we now have frontline maintenance and second line maintenance options that are FDA approved. So.
Correct. So this particular drug, as well as others in the PARP inhibitor class, can be used as either treatment for patients who have received a few lines of chemotherapy. They can also be used in the appropriate setting as maintenance therapy, either after their first regimen of chemotherapy or their second recurrence as maintenance therapy as well. And in some cases can even be used in combination with other drugs, either FDA approved or currently through clinical trials in combination with other novel strategies. There is one last question for Marlene before we end the session today. This question is asking about where patients can learn about these resources. And we are going to send her your handout from this webinar, and that should hopefully address her concerns.
Yes,
that was, sorry.
You can reach out, just so I know you're going to get the pamphlet, but reach out to the American Cancer Society. It's on the flyer. And also, you can also, if it's a medication issue, you can always look on needymeds.org, and they can also tell you what programs are available if your medication is not being covered by your insurance company. That's all.
Wonderful. Thank you, Marlene. That was our final question, panelists. Thank you so much for answering these questions this evening and sharing your expertise with us. Our last presentation has been pre-recorded for this program, but unfortunately, due to technical errors, we were unable to view it on today's webinar, and we apologize for this error. We are therefore going to email it to all of the attendees immediately after the webinar. And this includes patient advocacy, access to quality care, pharmacy benefit managers, or PBMS, and additional support resources made available through the Flasco patient portal. So we encourage all attendees to watch it. If you would like to be added to our mail list for patient advocacy, please email info@flasco.org. That's info@flasco.org. I'd like to thank all of our panelists again for presenting this evening and leaving us with this meaningful information. I'd also like once again to thank GlaxoSmithKline for sponsoring this webinar. After such an important discussion, I'm sure we've all walked away with something new that may positively impact our practices. As a reminder, all of the handouts mentioned in this webinar can be found in the handouts drop-down box on your GoToWebinar panel. So make sure to download them. Additionally, this webinar was recorded. So if you've missed anything and want to hear it again, it will be available at the Flasco website icon soon. Thank you for joining us tonight, and we hope to see you again in the future for another webinar.
Hello, I'd like to welcome you to the advocacy portion of our Flasco Living with Cancer series presentation tonight. My name is Michael Diaz, and I'm a medical oncologist and hematologist. I'm the Flasco Director of Patient Advocacy and a past president of Flasco. I practice medical oncology and hematology in St. Petersburg, Florida with Florida Cancer Specialists. And we're here today to talk about something that's pretty near and dear to my heart, and it has to do with patient advocacy. And so first of all, I'd like to start off more from the big picture perspective. I've had people tell me in the past, well, Mike, talk about advocacy. Tell them what it means. Well, I looked up the definition of advocacy in the dictionary, and all it says is to advocate. Very helpful, huh? So let me just explain. So advocacy, as far as I'm concerned, yeah, it's a general concept, but it means to advocate for, which means you're trying to do something to benefit somebody, whether it be yourself or somebody else. In fact, you all being here tonight to educate yourselves means you're advocating for yourself in the form of education, educational advocacy about a condition that might mean something to you or someone you know or care about. So yes, there's educational advocacy. Your doctors will also most likely advocate for you whenever they're fighting insurance companies to get scans or medications or therapies or testings approved. We really don't get paid any money to do that, and that's we either have to hire staff to do that or we do a lot of it ourselves too, but we're advocating for you. The way, and there are many other ways besides education, you can advocate for family members. You can help assist with certain components of their care, and all that is advocating. There are lots of ways to do that. The main way that I like to advocate for my cancer patients, because that's one of the reasons why I love being a doctor. In my free time, which is not a lot of, but I do spend a lot of time doing it, is I advocate for my patients when it comes to healthcare reform. One of the things that I noticed as I was going through my training as a young oncologist is that it didn't seem to me that there were a lot of healthcare providers involved with the policy decision-making process that would impact patient care, patients' health care, or their access to care. And one of the things that I've been doing since I've been practicing medicine for a little over 15 years now, I've been getting more and more involved with advocating for healthcare reform so that patients have access to affordable quality healthcare that's close to home. I'm a firm believer that we have enough resources in this country. There's no reason why people shouldn't have to spend their life savings or refinance their house just to get their cancer care. I think it's ridiculous. I personally think that the system is flawed in a lot of ways. And I think that there are a lot of people who are getting a disproportionate share of the resources, and those are not the patients, and I personally don't think they're the providers either. So that's one of the reasons why I'm involved with healthcare reform. And we do it in a lot of ways. I work with organizations of like-minded individuals, whether it be other oncologists or pharmacists. We have organizations. We work to advocate here in Flasco, mainly at a state level and also at a national level. But I do work with other organizations for synergy. And it all has to do with in understanding the healthcare system, which is extremely overly complicated. It needs to be fixed, but it's what we have, and we have to understand it to understand where the problems are so we know where we can fix things. So if we need to, instead of guessing, we will perform studies or commission studies to be done to better understand the little nuances of how potential things are impacting patient care or access to patient care. And then we also spend a lot of time educating our elected officials on this process, whether it be local in Tallahassee, whether it be going to DC, which we don't do a lot of traveling now, but I previously I would go to DC at least twice a month to help educate our elected officials there. We have to network a lot with Health and Human Services as well as Center for Medicare and Medicaid Services. And at a state level, we have to work a lot with the governor's office, the insurance commissioner, as well as Florida Medicaid for a lot of patient issues. And just to give you an idea of how effective you can be sometimes, for those of you all that aren't aware, about 4 years ago, the previous administration attempted a demonstration project that we will call the Part B Medicare Demonstration Project. And they thought, oh, we're going to save money. We're going to reduce the cost of care. And unfortunately, all it would have been doing was restricting access of care to possibly 50 to 75% of Medicare patients across the country, because it basically refused to pay for the more expensive treatments. Well, if you have cancer, you know that a lot of the time, the most effective treatments are the more recent treatments and are going to be the more effective treatments. Well, they were going to try to encourage you to use more generic medications. Well, the generic medications in cancer care are over 10 or 15 years old, and they're fairly outdated and not usually as effective as the newer medications. So it would have negatively impacted patient care. We went to grassroots across the country. We had to have all of our patients contact their representatives and their senators and tell them that they needed to shut this down. We were very successful in that it never took place. In fact, the following year, I went to meet one of our senator's healthcare aides, and she said, "You don't need to introduce yourself to me. Because of you, I had over 3,000 emails in my inbox. My email was locked. My email account was locked for several weeks." She said, "You did a great job with that. The senator wasn't listening to me, but when he saw how many people were concerned about this project, he said he realized he had to listen." So we can work together, and we'll talk more about that. I would like to move the discussion onto a more timely, more relevant, more current issue, which is known as pharmacy benefit managers. And most people aren't aware of even what a pharmacy benefit manager is. And just to give you a little background, the pharmacy benefit managers are who your insurance companies hire to manage your oral prescription benefits. They started off as just claims processors back in the 80s and 90s. All they would do is process insurance claims for oral medications. Well, over time, they evolved, they coalesced, they merged to the point to where there are essentially 3 pharmacy benefit managers that manage the oral prescription benefits for nearly 80% of all Americans. That's a lot of control and influence. Well, what happens when you have this control and influence? Stay tuned, we'll talk more about that. But these pharmacy benefit managers are so lucrative from a business perspective that they are merging with the top largest insurer companies in the country. In that one of the largest pharmacy benefit managers, CVS Caremark, recently bought one of the nation's largest insurance companies, Aetna. Well, 3 of the largest pharmacy benefit managers are owned or own some of the top 4 largest insurance companies in this country. So there's a lot of vertical integration going on. And it's because this component of healthcare has become so profitable. It's like, well, why has it become so profitable? Well, these pharmacy benefit managers, and more we're learning about this. In fact, this gets us to something that's near and dear to my heart, the price of drugs. I think the price of drugs are crazy. They're astronomical. They're very high. And it's difficult for patients to get their care because these newer medications and treatments cost so much. Well, studies are showing that when it comes to brand name drugs, we don't even talk about generics. It's a lot more complicated. Brand name drugs, probably well over 50% of the cost of any drug, whether it be oral drug or IV drug, over 50% of that is going to somebody else as a rebate. Yes, over half the cost of drugs. So if you're on a drug that costs $1,000 a month, over $500 of that is going to a rebate in somebody else's pocket, not the pharmaceutical company's pocket. So a lot of people like to complain to the pharmaceutical companies about drug prices, and I'm not letting them off the hook. But when I meet and I talk with a lot of the senior national executives in pharmaceutical companies, and they're aware of my stance that drug prices are too high and they need to get them under control and they need to do something about it. But part of the reason why the costs are so high is because of these rebates that are given out. Well, these rebates are from the drug companies, but they have to be built into the cost of the drug. And one of the nation's largest recipient of rebates are these pharmacy benefit managers and or insurance companies. Yes, the U.S. government via Medicaid and the VA healthcare system, they get some rebates. And they are a decent sized percentage of those rebates, but nowhere near as large as the rest of the rebates. In fact, some studies are showing that well over $150 billion a year in 2019 dollars was spent on rebates. And that's one of the reasons why the cost of drugs are so high. And when I talk with the senior people in pharmaceutical companies, they are somewhat traumatized after they have discussions with these pharmacy benefit managers because they have to talk with them and set up contracts before the pharmacy benefit manager will make their new medication available to the lives that they cover. And this is a typical comment I hear about that a pharmacy benefit manager would tell a pharmaceutical company. Wow, we really like that drug, your new drug. It's great, and we'd love for our patients to have access to it. But they need to know that we're working for them. So up front, we want you to give us a 10% discount off of the price so they can see we're working for them. And then after they've paid their copay, and after all the claims have been processed, on the back end, we want a 50% rebate. Otherwise, they will not even know your drug exists from us. And so these guys, they want their drugs to be available. And like I said, 3 of the largest pharmacy benefit managers control nearly 80% of the prescription benefits. If you don't let them have what they want or some version of it, your drug's not going to see a lot of patients or not even have the possibility to be used for a lot of patients. So there's definitely an issue with the rebate system going on. But also on the other end, the pharmacy benefit manager will also go after the providers. When I say the providers, the pharmacists, or in the case of cancer patients, if the cancer doctors are providing the drug, even the oncologist. They like to come back to us about, months after the transaction occurred, i.e. the prescription was given, and they'll just come back and say to the provider, either the cancer doctor or the pharmacy, and say, yeah, you owe us 10% of all this money. And it's like, why do we owe you 10%? So, well, you didn't meet quality measures. And this is exactly what was told to my practice. You didn't meet quality measures. It's like, we didn't know that there were quality measures. They said, well, you're correct. There's not any oncology or cancer specific quality measures. So, we looked at the cancer patients that you're taking care of, our cancer patients that you're taking care of, and we looked at their adherence rates to blood pressure medications, diabetes medications, and cholesterol medications. And well, they were all perfect and they were adhering to their medications. So we couldn't use that data. So we looked at the entire Southwest Florida regional adherence rate to blood pressure medications, to diabetes medications, and cholesterol medications, and we applied that to you. And because the compliance rate in Southwest Florida is not very good, you've got to pay this penalty. And, my people know that if we don't pay this, what's called a DIR fee, direct and indirect remuneration fee, then we get kicked out of network. We can't take care of our patients. And trust me, if we can provide the oral medications to our patients, they will have much better patient care than if it's provided by some third-party specialty pharmacy that's nowhere near here, that knows nothing about patients or patients' care. So we do what we can on our end to try to sustain those fees. But those are just examples. Now, that's how they affect the business end of the thing. That's how they affect the pricing end of the thing. But in order for these pharmacy benefit managers to make more money and to steer more traffic towards certain products, they develop these formularies. And these formularies are, I guess you could say, their versions of preferred drug lists, and that drugs that they like, and some might even say, yes, that might be the appropriate indication for the drug, but are they getting higher rebates on this drug, and that's why they like it or not? We don't know. All that information is privileged and considered to be proprietary. But they have these formularies, and we're seeing perfect examples of how these formularies that they're trying to implement on cancer patients, they don't really work. You have cancer, you know that you may have other unique healthcare conditions, and it's not like there's a plethora of medications with which you can choose from, which some might consider to be your best treatment option. Why? Because different medications have different adverse side effects, and some may have an adverse side effect profile that may be detrimental to you given your unique health characteristics, or may not be better for you given your unique cancer. And so it's very difficult to say that just because I have cancer and it is cancer type X, that you should always start off with this one medication that these pharmacy benefit managers are saying you should start off with. And I can give you a perfect example. Let's tie it into patients. One of the things that we do is that we collect what's called patient PBM horror stories. And I do want you to know, if you have had any of these horror stories, as I will be talking about in a minute, please type in the little text box your name so that we can, and the best way to reach you so that we can reach out to you at Flasco and get your horror story recorded. We do this at the Flasco level. We do it at a national level. I do it with a national organization I work with called Community Oncology Alliance. If you go to pbmabuses.org, that's P as in Paul, pbmabuses.org, you can see, unfortunately, volumes of horror stories that have resulted from these pharmacy benefit managers negatively impacting patient care. Just to give you an example, getting back to the formularies that we were talking about, we have several examples that have even happened here in Florida where a patient with a condition and other cancer and other medical conditions, for example, like bad kidney disease, should be getting, if you look according to routine formularies and what's considered to be the number one line of therapy, a medication that its number one side effect is that it can impact the kidneys. Okay, well, one of my partners saw this patient and realized, wait, this patient needs this medication. It could impact the kidneys. They have bad kidneys. Then maybe we need to start them on the second line medication first, period, and avoid this potentially more dangerous one. They sent the patient to a local cancer center of expertise, and their specialist in this cancer said, yeah, you can't have that number one, that first drug, that first medication. You need to start off with the one second on the list because it could hurt the kidneys. Well, it took the pharmacy benefit manager over 2 months to approve the medication because it was denied because it wasn't number one on their formulary list. So we have several examples of where they can delay access to timely care. We even have examples nationally of patients just dying while they're waiting for their medication to arrive. An unfortunate example of a patient who waited 9 weeks for a routine metastatic breast cancer medication to arrive, but the pharmacy benefit manager fought with the provider for so long, the patient gave up after 8 weeks, went into hospice. The medication showed up just after that, but the patient was too weak to even take the medication. We have other examples of where the pharmacy benefit manager, I have 2 examples in my practice, not with me, but with 2 of my partners, of where the pharmacy benefit manager actually said, no, we know this medication is front line and is the first one that's listed to be used, but we think the patient should have surgery first. And in both instances, even the surgeon and the medical oncologist said, no, surgery is contraindicated in this patient. They said, well, no, we think the patient should have surgery first. So they're making a medical decision without even seeing the patient. They're making a medical decision without a license to practice medicine. And that's one of the things they're doing to save money and to help their bottom line. These guys are businesses. They took an oath to their shareholders. They did not take an oath to patients like the doctors did. And so if you have a horror story, please type it in on the question box so that the people from Flasco can contact you, hear your horror story so we can get it documented. We need to have these documented. And part of the reason why is that we are working on trying to reform the healthcare system as far as these pharmacy benefit managers are concerned. We're working both at a state level and at a national level. To give you an idea of what we've been doing at a state level, in fact, we've been coordinating with other healthcare advocacy organizations, and we attempted to have legislation passed last year for pharmacy benefit managers. It would have held and made sure there was transparency as well as accountability, because right now there's no transparency. I was in DC a couple of years ago and was talking with some key staffers on both the Senate and the House, and they said, yeah, the pharmacy benefit managers people were up here yesterday and they were lighting their hair on fire saying, oh no, we can't be transparent. That will disclose proprietary information. We won't be able to save money. There's no way we can be transparent. Well, this is healthcare. Everybody needs it. And if you have to be that transparent, then is there a reason for that? So we want reasonable transparency and we wanted accountability. And unfortunately, that bill did not pass. It did not go up for vote in the House or the Senate, but we will be working on that again for next year. And that's one of the reasons why I want to grab your attention. We will be working on that next year, and we will need your help with reaching out to your legislature, your state representative and your state senator, so that they will know they need to support this bill. Now, with that being said, to give you a little bit more of an idea of how conniving these pharmacy benefit managers can be, one of our other organizations developed a study looking at Florida alone, just to better understand how these pharmacy benefit managers worked in the Medicaid system that's run by the state. And just in one example, with a generic medicine, they saw that the pharmacy benefit manager was paying a pharmacy that they didn't have a preferred contract with. They're paying this pharmacy approximately 20 cents a pill for generic medicine the patient needs to take twice a day. And they were paying a pharmacy that they had a contract with. Now you got to keep in mind, this contract that they have with the pharmacy is not accessible to the public. Why? Because it's proprietary. Well, they were paying them $10 a pill. And when you sit down and you look at things, it would not be reasonable, given the fact this medication is taken twice a day, every day, within a year, if you assume a reasonable number of patients are on this medicine, it's a commonly used medicine, very commonly used medicine, that it wouldn't be reasonable for there to be a $30 million discrepancy going into this preferred pharmacy's pocket. So that has caused a lot of uproar in Florida. That was not able to get this legislation passed, but it was able to get the governor to hire a nationally renowned actuarial firm to do their own study to validate and verify what this other study has seen. If there's that large of a discrepancy, then if it's the taxpayers' dollars, I think the taxpayer deserves to know, why is this pharmacy getting paid so much more for pill than your average pharmacy? Okay, that stuff needs to be known. There's been a lot of reform going on at the state levels because of little tactics like this, especially in Florida, especially in Ohio and Georgia. We want Florida to be next, and so we'll be reaching out to you to advocate more next year. We're also working at a national level in DC with a couple of different bills, a couple of pieces of legislation, one so that patients could get their drug within 48 hours and they wouldn't be waiting several weeks or even months to get their medication. Now, some of that stuff's been put on hold because of COVID, but we plan on bringing that up at the beginning of next year, because right now, with the way things are in DC, not a lot's happening at all within the next several months because of COVID, because of the elections, but we are working on it as we can. So your involvement is essential. As I told you with the example, when it comes to healthcare reform, if your elected official hears about you, the voter, and they hear that you are concerned, they will listen. And we are planning on this next year, for this next 2021 legislative session, we are planning on having a bill introduced to help reform pharmacy benefit managers, but we need to have a coordinated effort, because there might be more than one bill out there. We want to make sure that you are sponsoring the correct bill. We want to make sure that you know why. So it's a good idea, I think it would be, if you are interested and want to help verbalize your opinion as a voter to your elected officials, that you put your name and email in the question box. Let them know you want the monthly newsletter. It's a monthly patient newsletter. That's one way to stay updated. Not only will you learn about advocacy issues, but you will learn updates about all the different things that we talked about today. And just as well, you can go to the website at www.patients.flasco.org to learn more about not only advocacy information, the things that I'm talking about here today. Once again, it's to make sure there's a coordinated effort so that you know when to reach out to your elected official, you know what to talk about, you know which bill to tell them they need to support, but it's also to learn more about other things for patients, such as assistance programs, various support groups, as well as clinical trials, and yes, of course, something important and dear to me, information about advocacy. And also, we plan on notifying all the patients that have participated in these Living with Cancer series when there is a time we need to call them to action, because you can help us, the providers, make sure that you have access to care that's affordable, quality, and that people are not taking all the money that's being designated for healthcare, instead of it going to the patients, they're putting it in their pocket. We got to put a stop to that. So I appreciate your attention, and please sign up for the newsletter, go to the website. Any questions, once again, please direct them in the question box. Your questions will be answered, but you all have a great evening. Thank you. God bless.